topic is metabolic adaptations in prediabetes, the precursor of silent diabetes. When we all, I see most of other students, and when we are as a student, and when I was a student, biochemistry was the subject which was least interested in. We were like, mug up something and just clear the subject. But when I started practicing and I understood that, okay, as a student I have a question, why I have to learn all the cycles and all the system, but then I realized, okay, everything revolves around that. Our human body is a biochemistry and the physiology. And that is how I actually started learning the biochemistry and understanding that how it, how it affects entire metabolism and all your system, all your hormones, all your enzymes. So, to all my clients or patients and friends and relatives, I always say that don't worry for your wrinkles, but worry for your enzymes, hormones, and all that. So today my topic will revolve around the insulin resistance, adipose tissue dysfunction, inflammation and oxidative stress, mitochondrial dysfunction, glucose dysregulation, hepatic glucose production, skeletal muscle insulin resistance, lifestyle factors. This is entire one subject I try to cover in 20 minutes. So before starting, I would like to end a little bit spice so that we continue to learn. So the pre-diabetes term, when it is coined by the ADA more than 20 years back, it was very controversial because initially it was termed as an impaired glucose tolerance or impaired fasting glucose. So when this term was coined, there were two categories of the population. So there was opponent and there was a proponents. So proponents said, yes, it is a good to term it as a pre-diabetic because there is still an alert to the populations where prevention is still possible. There are a lot of studies have seen that there is a significant number where at the pre-diabetes we can still reverse and remit, and you has already said that even the diabetes can be remitted. Now, there was an opponent which was saying because there was a large populations who were pre-diabetic. So if we consider this in medicalized populations, it will be a large proportion of the populations who will be coming or falling under the medicalization. But to all this chaos, the pre-diabetic term was coined, and then different organizations and institutions have set the criteria for the diagnosis of pre-diabetes. There are many, but I have just put 2 or 3 to understand by the WHO, ADA, and International Expert Committee. Now, why it is important to identify people with pre-diabetes? Because being in our country, we are very ignorant about our health. We don't observe the responses of our body, and pre-diabetic is a time where we can still take a charge of our health and avoid medications, avoid going into the diabetic and related complications. So pre-diabetes can lead to macrovascular and microvascular complications such as cardiovascular disease, type 2 DM, cerebrovascular disease, retinopathy, neuropathy, microalbuminuria, nephropathy, and peripheral vascular disease. So if we wake up at the pre-diabetes, we will be able to avoid all these microvascular and microvascular complications. Pathophysiology. As far as I have understood pre-diabetes, it revolves around 4 key components. It is abnormalities in insulin secretion, it is insulin resistant, increased lipolysis, and dysregulated hepatic glucose production. So if the content which I have presented, everything is, okay, yeah. So everything revolves around all 4 key components, and all the metabolism or dysregulations end up in any one of or multiple of these things. Right? So ultrasound insulin sensitivity and insulin resistance, pancreatic beta cell dysfunction, inflammatory cytokines productions, decrease in the incretin response. Now what is incretin response? So incretin response are basically there are 2 hormones which is responsible for the incretin response. Incretin response is basically directly related with the secretion of the insulin. So as soon as we eat food, physiologically, immediately the incretin response is activated. There are main 2 hormones, as I said, GIP and GLP-1. So these two hormones stimulate your pancreas, where your beta cells are stimulated, and it secretes the insulin, which takes care of your blood glucose mostly. Now, when this incretin response is decreased, it will decrease your insulin secretion, and thus your blood sugar levels will not be able to be in control. Now, hepatic glucose production. So, this all are the metabolism which leads to or which revolves around the prediabetes. Insulin resistance as a precursor. Now, this is I can say a first stage is the insulin resistance and second stage is the prediabetes. So, what is insulin resistance? For that, we first need to understand what is insulin. So, insulin is basically hormone, which in a very layman term I will say it acts as a pulley which takes up your glucose, pick it up and put it into the cell. So, insulin basically helps your glucose uptake to the cells. Right? What is insulin resistance? Insulin resistance is now who takes this glucose, right? So you have your liver cells, muscle cells, skeletal, your brain, all this takes up the glucose. Now when insulin resistance is there, what happens that the efficiency of insulin to take up the glucose and put it to the cells is hampered, right? So though your insulin secretion is fine, but the quality of the insulin, the sensitivity of insulin is decreased, so the amount of uptake of glucose which is taken by the insulin is not up to the mark, or it is hampered, right? So this is the insulin resistance. Now, when we say insulin resistance, how we can identify insulin resistance, right? How we can identify the insulin resistance? So, usually prediabetes doesn't have any symptoms, but if you closely observe them, you can see the black area around the back and around the neck, which is also called as an acanthosis nigricans. You can also observe small skin tags on the skin, which is the early symptoms of the prediabetes to identify the resistance. Who all are likely to have this are physically sedentary lifestyle, overweight, obesity, female were already diagnosed with the gestational diabetes mellitus during their pregnancy. Also, some ethnicity are very prone to have this diabetes. And lifestyle, sedentary lifestyle and overeating. Now, what happens in insulin resistance? As we have said, our mitochondria is a powerhouse of energy. So, all bioenergetic is happening in our mitochondria. Now, during that energy process, when there is insulin resistance, it will lead to production of ROS. RO is a reactive oxygen species. It is a byproduct of the energy cycles in our body. But adequately taken care by the antioxidant of this ROS, it doesn't harm your body. But when you don't have enough antioxidant activity in your cells, this reactive oxygen species increase the oxidative stress and lead to tissue damage. Impaired glucose oxidations, impaired fatty acid oxidations, all this can lead to metabolic inflexibility. And this will increase insulin resistance and it will not allow your organs or muscles, liver to take up the glucose. Another is the adipose tissue dysfunction. Now, adipose tissue dysfunctions basically affect the two hormones, leptin and adiponectin. Even adipose tissue dysfunctions can also be diagnosed with the ratio of both these hormones. Now, we have already seen in Luke's presentations that what leptin does. Basically, it suppresses hunger and induces satiety. What adiponectin does? Now, adiponectin is our friend, right? So, it has a high antioxidant activity and it also improves the insulin sensitivity in the secretion. So, when adipose tissue dysfunction happens, your leptin goes up, your adiponectin goes reduced. Result of which it can lead to hyperlipidemia, which can be measured by the serum levels of LDL, triglycerides, and HDL. It can also lead to chronic inflammation, which can again diagnosed by taking CV active protein levels, And insulin resistance, especially in pre-diabetes of more insulin mode, where increased glucose production, increased insulin resistance, and hyperinsulinemia is the reason, right? Which can lead to endothelial dysfunction. Now, as I was talking about the inflammation and oxidative stress, where we have spoken about the ROS. Now, different bioenergetics, we have a different cycles for glucose homeostasis. So we have a different cycles like polyols, we have a pentose pathway, we have a glucuronide pathway, we have a glycogen turnover, we have a advanced glycation end products pathway, we have a hexosamine pathway. So when there is a metabolic inflexibility, there is a changes in the way this all cycle functions. So there are not all the cycles which is producing the inflammation or reactive oxygen species, but there are few cycles which are hampered and can lead to the production of the reactive oxygen species. Now, when there is a hyperglycemia, it affects at two levels. It also alters your gene expression and it affects at cellular level. So when it affects at two levels, there is a activation of toxin pathways of glucose, right? Which produce the reactive oxygen species. Now, which are these pathways? They are the polyol pathway, there is a age-range pathway, there is a PKC, protein kinase C pathway, and there is a hexosamine pathway. Now, all these pathways, if you see, polyol pathway, conversion of glucose to fructose and sorbitol replace the antioxidant capacity. So, it is again affecting your inflammation process, where instead of anti-inflammatory, it is increasing the inflammation. What is your age-range pathway does, which is advanced glycation end products? Tissue modification by age is and binding to receptors alters gene expression. So there are some genes which is responsible for the glucose homeostasis are altered by this pathway. PKC pathway, protein kinase C pathway. In this pathway, glucose-mediated activations of protein kinase C alters the expression of inosed nitrogen oxide, WAVE, Pi, TGFB, which is your cytokines, and reactive oxygen species. Hexosamine pathway. This pathway, glucose flux through the pathway produce UDP and acetylglucosamine, which can modify proteins and alter your gene expression. So this way, the entire glucose toxic pathway is affecting your gene expression and also affect you at the cellular level, which can cumulatively lead to the tissue damage. Now, mitochondrial dysfunctions. Coming back to basic of the first slide. As we all know, mitochondria is a powerhouse where we generate our energies, right? Via using the different pathways. Now, when we see the mitochondria, as we have known that either it's an insulin secretion, either it's an insulin resistance, or dysglycemia. Now, when these things are dysregulated, it affects or activated by the organs. So, which organs are mainly affecting? Which is your skeletal muscle, which is your heart, which is your liver, which is your brain, which is your pancreatic cells, right? So, these all organs are somehow affected and it disturbs the glucose homeostasis. In the process of disturbance of glucose homeostasis, it also activates the production of the free fatty acids. So, when this all energy homeostasis and glucose homeostasis is disturbed, there is an increase in the blood sugar level, there is increase in the free fatty acid levels, and thus it increases the oxidative stress and the inflammation. So, as I said, stage 1 is insulin resistance, stage 2 is prediabetes, and stage 3 is a type 2 diabetes. Along with the diabetes, it's not only the complications of prediabetes, but the cardiovascular disease, hypertension, this all are also the complications of prediabetes. Glucose dysregulation, this was not much of my topic, but I heard one of the lecture of Dr. Shilpa Joshi, and which has motivated me to add this glucose dysregulations. Lot of people who has a normal glucose level, normal blood glucose level, have shown that at times the glucose levels are at the pre-diabetic level or even at the diabetic level. So sometimes what happens, we are measuring at the fasting and my fasting sugar comes normal, but I am not monitoring my continuous glucose levels. So though I understand that I am normoglycemic because my fasting levels are normal, but maybe my entire day glucose response is not as per the normoglycemic level. So there was one study done, and many more studies I expect that we should do in India, that how our meal responses to the blood sugar level. So severe glucose variability was present in a 25% of normoglycemic individuals. And within this subgroup, glucose reached to pre-diabetic and also diabetic glucose levels at 15% and 2% of the time respectively. The same study also did monitor the blood glucose level after consumption of the breakfast. So the subjects who were normoglycemic before the breakfast, they were given the breakfast of bread and protein bar, just a bar and the cereal, which is the usual breakfast of the Western countries. This study was done in the Western countries, hence the breakfast pattern is like that. So there are some foods that result in elevated glucose in the majority of adults. A standardized meal of cornflakes and milk caused glucose elevation in the pre-diabetic range. So most of, even in our country, have shifted to the cornflakes and milk as a breakfast. And if you see in this study, the cornflakes and milk has the increased in the blood sugar level. Now normoglycemia. As I said when I was talking about the incretin hormones, the DPP4 deactivates your incretin hormones very rapidly. So when your DPP4 is active, your incretin hormones are deactivated. Then insulin secretion is going to be affected and loss of the genetic control where you alter your gene expression. Hepatic glucose production. Central role of the liver in the regulation of glucose metabolism. So we all know that liver, where it is responsible for basically two cycles, gluconeogenesis and glycogenolysis. Both are when our body needs sugar, it breaks down the glycogen and bring our glucose to the blood. And when there is an excess of glucose, it takes the glucose, convert it to the glycogen, also induce the lipogenesis. So basically these are the two metabolic functions of the liver as far as glucose and glycogen is concerned. Now what happens that when you have insulin sensitivity is decreased, when you have an insulin resistance, when the insulin secretion is decreased because of the decrease in the incretins, your two things happen. Your insulin and glucagon both are activated. Right? Why insulin is activated? Because there is a insulin resistance. So the available insulin is not enough for taking up the glucose. So insulin's pancreas work hard and give more insulin, right? Which will lead to a hyperinsulinemia. What happens same time? Because the glucose is not going to your liver, skeletal muscles, so they feel there is no glucose, so the signal goes to glucagon. And glucagon also start working, so your liver start taking the glycogen. Hence, the glucose production by the liver starts. So already there is a high blood glucose in the blood which is not taken care by insulin. Pancreas is working hard, so hyperinsulinemia. And when your glucagon start working, so further more glucose comes into the blood and it leads to hyperglycemia. So all together leads to hyperinsulinemia, hyperglycemia, and beta cell dysfunctions. Skeletal muscle insulin resistance. So we have learned about the adipose tissue, mitochondria, liver. Now last is the skeletal muscle. The skeletal muscle is an organ system which is largest in the body, comprising about 40% of weight of a young man. And that is why we need to exercise and build our skeletal muscle and muscle mass. The skeletal muscle is the largest organ in the body. It is also the regulator of glucose homeostasis, responsible for 80% of postprandial glucose uptake. which I would like to connect with the Luke's lecture where he said after your meal you should at least walk for some time so that you will improve the glucose intake by your skeletal muscles. Right? Now, insulin resistance, which is caused by the desensitization of this muscle to the insulin results by the pancreas, do elicit your glucose uptake, leading to elevated blood glucose levels. Skeletal muscle insulin resistance can appear decades before the onset of beta cell failure and symptomatic type 2 diabetes. So it is also one of the important factor for the pre-diabetic which can be considered. This is just the pathway where again it has explained that how fatty acid oxidant production of ROS and glucose and insulin resistance has contributed to pre-diabetes. Now there is a last but not the least and very important, that lifestyle factors and metabolic adaptations. Right? So physical activity, your body weight and your food and certain habits definitely influence your metabolism. So if we talk about the body weight, if you are at the high body weight or if anyone is at a high body weight, there is a proliferation of the macrophages, overexpression of the translocase gene, and obesity impacts the ability to secrete the insulin. So overweight also affect the insulin secretion and the insulin sensitivity. Whether the reduction in the body weight has shown the improvement in the secretion and the sensitivity. Right? As I mentioned, certain habits, smoking. Now when someone smokes, there is an aging of beta cells, an accumulation of ROS, this is the reactive oxygen spaces in your beta cells, which again increase your inflammation and oxidative stress. Next is a diet. If we have a diet which is high in lipids, especially trans fat and processed fat, which we all are consuming in a large amount, the lipotoxicity can disrupt the C36 gap functions. High fat diet leads to inflammation of the hypothalamus. High fat diets can activate 12 lipoproteins activity in beta cells. So thus high lipid diet and how the adding of polyphenols in the diet and replacing the high lipid to the MUFA and polyunsaturated fat helps in the improving the reducing the inflammation. Physical activity, of course, Luke has given the good information on the physical activity. So accumulatively, if we consider all the metabolic factors, in summary, if we see that how it is very important to understand the pre-diabetes, it is very important to identify the people around you or your clients, especially who are overweight, especially who are sedentary, that neither they have any symptoms of the pre-diabetes. If they have any symptoms, then start working on it because still you have a potential to remit or delay the onset of the diabetes. There are a lot of factors which affect where you have a genetic factors where you can, as a part of my study nutrigenomics, we know that we cannot change a gene, but we can change the expression of our genes. So exercise, diet, lifestyle, everything helps us in the changing the expression of our genes. Age, hypertension, dyslipidemia, all this contribute to the pre-diabetes. Thank you.